Okay, so let's go. What are the top 10 asthma papers? These are the 10 asthma papers that the pulmonary critical care fellows and residents should be familiar with. So the first trial is the CAMP trial in 2000, New England Journal of Medicine. We're looking at a pediatric trial, fit 5 to 12 years age, mild, moderate asthma, 1,000 patients, 1,041, and it was 4.5 years. Budesonide versus nadocromil versus placebo. Budesonide decreased hospitalizations, ER visits, OCS courses. There was no change in post-bronchodilator FEV1, but the ICS suppressed inflammation, did not reverse established remodeling. This is why you start early. It prevents, it doesn't repair. It preserved the lung trajectory, even mild childhood asthma. What is interesting out of this is really it showed the safety in longer term steroids, and this was an important trial when it comes to looking at inhaled steroids. Paper number 2 is the Rowe Cochrane database in 2001. We're looking again at adults and children, 12 randomized controlled trials. Um, and basically, the number needed to treat was 8 to prevent one admission. That would be if you started early steroids. Um, Oral and IV steroids were equally effective in acute asthma. Oral is preferred when the patient can swallow. It's faster, cheaper. You don't need IV access. And the relapse at 7 to 10 days was much less if you started early systemic steroids. This is adopted 24 years later in the GINA 2025 timing that you give steroids systemically within 1 hour of systemic exacerbation. You don't wait for a nebulizer response. Any acute asthma that requires more than initial SABA, you should start with the systemic steroids, same dose oral versus IV. And the number needed to treat is 8 to prevent the admission. So that is where we get this odds ratio 0.4. This is from the early trial Rowe database back in 2001. The FACET trial is number 3, New England Journal of Medicine, 1997. This looked at ICS plus LABA synergy is mechanistic and not just additive. So they looked at moderate to severe asthma, 2x2 factorial design, 852 patients, budesonide plus or minus formoterol. So the low dose budesonide was the reference group. They had high dose budesonide, which decreased severe exacerbations by 49%, and then the high dose plus formoterol decreased severe exacerbations by 63%. So formoterol upregulates the steroid receptor. ICS becomes more effective at the same dose. And so this was true molecular synergy, not additive bronchodilation. This is the mechanism behind every combination inhaler. So again, why does the ICS become more effective? Because the formoterol, the long-acting beta agonist, upregulates the steroid receptors. So every ICS LABA combination is really built on the pharmacologic insight from the FACET trial, which was published in the New England Journal of Medicine 1997. So we're talking Symbicort, Advair, Dulera, Brio. These are the combination ICS LABAs that we have. It's mechanistic and not just additive. And so there's a molecular rationale behind these combination therapies. Number 4 is the GOLD trial in Lancet 2004. We're looking now at mild to severe asthma, stepwise escalation, fluticasone versus fluticasone and salmeterol. And the patients who were on ICS LABA were more likely to be well controlled if they had mild, as they were going up, mild to moderate severity. Patients achieving totally controlled asthma, ICS alone only 28%, and ICS LABA 41%. So why does the totally controlled matter? Because there's no daytime symptoms, no nocturnal awakening, no rescue SABA, normal activity. The target is not just better than before, but no exacerbations and normal activity. So ICS LABA achieves total control faster at every severity stratum. This is the GINA steps 3 to 4 evidence base. Symptom control is the minimum, total control is the goal. So you treat to control symptoms, not just the symptoms. You treat to total control. And ICS LABA achieves it faster at every severity. Remember, GINA step 4 is the one where you have daily symptoms. Remember, step 4 is for daily symptoms. Then we have number 5, LABA monotherapy is a fatal mistake, Chest 2006. Asthma patients, we're looking at salmeterol plus or minus ICS, 26,355 patients. The relative risk was higher, 4.37. In asthma-related deaths, this is not cardiac deaths, this is not arrhythmias, this is specifically respiratory-related deaths, 13 versus 3. That's where the FDA black box came out in 2005. The highest risk, the signal was strongest in patients not on background ICS. Why it happened, the LABA masks symptoms without controlling airway inflammation. So patients feel better, reduced ICS use, while the eosinophilic inflammation increases. A sudden severe exacerbation catches them unprotected. ICS is needed. It's not optional. It must never be prescribed without ICS ever, no exceptions. Of course, we eventually saw that the ICS is a protective. So even though Advair and Symbicort actually carried the black box warning for quite some years, it was finally let go because of the protective factor of ICS that was proven. Paper number 6. This is sort of new in the 2025-2026, SYGMA 1, SYGMA 2, novel start, and BATURA. So let's look at this. There's really one message. As needed, anti-inflammatory therapy is the new standard. So let's look at SYGMA 1, 3849 patients. So you had PRN, budesonide, formoterol versus PRN, SABA, decreased exacerbations by 64%. That's SYGMA 1. SYGMA 2, we're looking at PRN, budesonide, formoterol versus daily ICS, and it was non-inferior for exacerbation control. This is mild to moderate asthmatics, less total ICS exposure. The novel start, New England Journal of Medicine, 2009, 675 patients, PRN, budesonide, formoterol versus the PRN, SABA, decreased exacerbations, 51%. This was in mild step 1 asthma. And then the BATURA, New England Journal of Medicine, 2025, albuterol budesonide, otherwise known as Air Supra versus albuterol, decreased exacerbations, 47%. And the FDA was label was updated in 2026. So in the GINA 2025, FDA 2026, SABA only reliever eliminated at all steps, PRN ICS formoterol steps 1 to 2, or ICS formoterol as both maintenance and reliever in steps 3 to 4. And the Air Supra, remember, after the BATURA is FDA labeled for mild asthma. So again, SYGMA 1 was versus PRN SABA, SYGMA 2 versus daily ICS. Novel start was basically like SYGMA 1, and then BATURA was the Air Super trial. And then the biologics in 2005, we have omalizumab, IgE, and then the IL-5 mepolizumab. Eosinophil count changed everything. So the INNOVATE trial is the omalizumab one, and the MENSA is the mepolizumab. The INNOVATE trial was the decreased exacerbations by 26%. And this is for patients with high IgE and allergic sensitization, which basically means one perennial antigen positive, let's say dust mites positive, or anything in the allergy panel will be positive, plus a high IgE, you could use omalizumab. The MENSA trial showed a decrease in 53% exacerbations, and that was with an eosinophil count greater than 150 as the defining biomarker for anti-IL-5 biologics. And these trials launched the biologic precision in asthma. Again, IgE omalizumab, IL-5, mepolizumab. Paper number 8 is basically a combination of the trials benralizumab, dupilumab, tezepelumab, and depemokimab. So now we're talking about moderate to severe uncontrolled asthma and high-dose ICS-LABA. And these are the different trials: Sirocco, Quest, Navigator, and Swift. So let's go over just Sirocco. Basically showed decreased exacerbations by 50%. Dupilumab showed decreased exacerbations by 47%. Tezspire showed decreased 56%, and depemokimab 55%. So this is eosinophils greater than 300, any IL-5 or IL-5 receptor antagonist, or dupilumab, which is, by the way, an IL-4 receptor antagonist, or Tezspire, which is it works higher upstream. EOs less than 300 or non-eosinophilic, that's when you would use the Tezspire or dupilumab. And of course, dupilumab is used with Sturg-Strauss and atopic dermatitis. It's used with um, corticoid requiring asthma as well. So if you see a patient who needs steroids and asthma, that's the one that dupilumab um, is specifically indicated. Okay, so now you have the OCS sparing imperative. These trials, the Venture, Wayfinder, and Sunrise trial, also new. So the idea is to try to get the patients off the steroids. This is basically what I was referring to. 70% decrease in OCS versus placebo if you use dupilumab. 48% limited OCS, decreased exacerbations by 59%. The Wayfinder Tezspire 89.9 achieved less than 5 milligrams a day, pretty good. And the Sunrise trial, ATS 2026, again, showing Tezspire got you 36% off OCS entirely. Again, not as good as the Venture trial in dupilumab. So every year on chronic OCS and asthmatic increases your diabetes risk, increases fractures, cataracts, and cardiovascular mortality. The GINA 2025 Step 5 goal is OCS elimination, not dose reduction, and biologics make this achievable. Now you can say the trials are Venture, Wayfinder, and Sunrise. And then the last trials to discuss are the Iridium and Captain trials, where you should try ICS LABA LAMA step 4 before you escalate to biologics. So the Iridium is 3,000 patients, 41 countries, whereas the Captain trial is 2,436 patients. So if you look at the FEV1 improvement was 74 cc's in the Iridium, and the Captain trial is about the same. Decreased exacerbations by 10 to 20%, strongest in the highest eosinophil group. Now, so ICS LABA LAMA is the last inhaler before you start biologics, real lung function gains, particularly in patients with fixed airflow obstruction or high eosinophil counts. So you try it first, and then you escalate to biologics if you're still uncontrolled. So you try ICS LABA LAMA step 4 before biologics. The largest once daily globally validated trial is the Iridium. And again, there were real FEV1 gains compared to just ICS LABA. 4 more you should know. You should know the 2025 GINA, PRN ICS formoterol, steps 1 to 2, biomarker-driven biologic selection at step 5, OCS elimination primary goal. Mandala is the Air Supra initial approval, moderate to severe asthma, New England Journal of Medicine 2022. BATURA extended to mild asthma, completing the spectrum. So again, Air Supra is also approved as a rescue inhaler, moderate to severe asthma. And then the MARCH strategy meta-analysis, where in 2010, ICS formoterol was both maintenance and reliever therapy. It's called the MARCT. Reduced severe exacerbations versus fixed ICS LABA plus SABA. That's where the GINA 2025 gets their step 3 to 4 endorse strategy. And then FeNO guided ICS dosing, elevated FeNO Type 2 airway inflammation, again, IL-4, 5, and 13. It's demonstrative with elevated fractional excretion of nitric oxide. You prefer dupilumab or mepolizumab for biologic selection. And again, the top 10 asthma papers at a glance: Camp, Rowe, FACET, showing synergy is mechanistic. Goal, you try to control, total control, not just the symptoms. SMART trials showed the danger of monotherapy. SYGMA novel start BATURA, you need every puff must contain ICS. INNOVATE MENSA shows the beginning of the biologic era, then benralizumab, dupilumab, Tezspire, and depemokimab, which is the every 6 month, and then Venture, Wayfinder, Sunrise, OCS elimination, and Iridium Captain, to remind you that triple therapy should be started even before the biologics. Thank you very much for listening.